So the client we'll be working with is 56-year-old male Ken, who currently works as a plumber. He comes to us suffering with chronic lower back pain, which is causing problems on and off for the past 15 years. Ken has seen several allied health professionals, but has yet to have any luck. We do know that Ken actually had an MRI done 5 years ago, which reports posterior disc bulge at L4, L5 and signs of disc degeneration at L3, L4, L4, L5, and L5S1. Overall, Ken presents as quite skeptical of performing exercise due to his symptoms and bad past experience. He's also said that he gets pain working on jobs that require him to squat and bend forward for prolonged periods of time. Furthermore, Ken has mentioned that in our initial consult he occasionally gets mild right shoulder pain when lifting his arms over his head playing cricket in the backyard with his daughter. Okay, so just covering some of the pathophysiology here on what's going on in Ken's lumbar and sacral spine. So starting on the top diagram in the white box, we see a top view of a normal and healthy vertebral disc in which are positioned between the end plates of each vertebrae, which is also in orange. The inner pink part you can see is the nucleus pulposus, which works to resist vertical compressive forces and translate the force into the outer blue layer, which is known as the annulus fibrosus. Now, the annulus fibrosus itself is able to resist tensile, meaning stretching, torsional, which is twisting, and shear forces, which works horizontally. So shifting to the image of the spine on the right, we see the red line located at L4, L5 disc where the bulge is occurring on Ken, and a visual representation of that being the bottom left image. A disc bulge can occur through a traumatic event, which is possible, or more likely in Ken's case through repetitive loading, which we see in his long-time career as a plumber, fixed in bent-over positions as he describes. So what can happen here from either situation is a tear in the annulus fibrosus, where the nucleus pulposus can then push out into the vertebral foramen here that you see in the diagram, placing pressure onto the spinal cord, where in many cases individuals will experience symptoms such as pain, like we see in Ken, or even radiculopathy. But it's also possible to experience neither when this happens. And quickly between the white lines here on the spine figure on the right again, we see the disc in L3, L4, L4, L5, and L5S1 showing signs of degeneration, which is also known as osteoarthritis and can be quite common in the aging process. Here we see a lack of wear and repair, where this is a loss in cushioning, and again we can see similar symptoms. And moving on to some outcome measures here, beginning with the orthopedic testing, we see positive on the right for the slump and straight legs raise test, which stands out to us as suggesting neuro issues that could be indicative of the disc bulge occurring in Ken. The quadrant test was negative, which is done to assess whether pain can be provoked by the facet joints, which can now be ruled out, and positive in the empty can for the right side, yet negative on both in the full can test, which are both done to test the integrity of the supraspinatus muscle and tendon and indicate whether pathology is present. These results, while less clear, suggest possible but uncertain shoulder impingement, as both are not a completely reliable diagnostic tool. The takeaway here being that we note this is a pain-provoking movement and likely that supraspinatus pathology is present due to these symptoms. And for range of motion, we see pain in trunk flexion at a 3 out of 10 due to the disc bulge that is shifting posteriorly, and tight hamstrings the moment the hands pass the knee, which is extremely poor if it is flexibility issues, but could be subject to neural factors with the bulge. Extension is relieving for him, whilst the hips range of motion are poor overall, which can certainly be contributing to his lower back pain, but we see even worse on the right side, possibly due to activities work favouring one side, but can also suggest that this bulge may be more to the right side also. For shoulder range of motion is slightly below norms, more so on the right side again, but the big thing here is that we see a painful arc not so much in line with criteria to indicate a certain pathology, but it is certainly present and will be considered for prescription. Manual muscle testing, where weakness was indicated in the trunk extension, hip extension, knee bent, focusing glute max, and right-sided shoulder flexion, abduction, and external rotation, with abduction and external rotation presenting with a 2 out of 10 pain. Finally, for functional testing, we see here that there's an inability to resist flexion, extension, and lateral force in the trunk, more so on the right side again for lateral, which indicates weakness in all these areas as they're below norms. We can also see in the single arm wall push-up noticeable scapular wing, suggesting weakness or less likely pathology within the serratus anterior muscle. For goals, let's start with client Ken's. He'd like to reduce lower back pain, reduce right-sided shoulder pain, be able to work pain-free and without these limiting factors. He wants to be able to continue leisure activities such as playing cricket with his daughter, where we see that overhead movement to be quite aggravating. For myself as a practitioner, in order to start achieving these goals for Ken, we want to improve range of motion in both his hips and right shoulder, be pain-free range of motion in that right shoulder, improve trunk strength endurance in all planes of movement, with greater postural control also, improve strength in the shoulder for specifically flexion, abduction, and external rotation. All of these will contribute to his next goal in reducing pain of the lower back and right shoulder, which is crucial in this intervention. And finally, return to work and these leisure activities described, pain-free and also confident within himself that he can, ensuring that there is no fear there. So here's the initial session that is to be completed by Ken in clinic and can be done in under 60 minutes, beginning with a 5-minute continuous low-intensity walk on the treadmill before shifting to dynamic hip and shoulder stretching in conjunction with PNF for the hip, all of which are shown by research to be effective measures in preparing the body for exercise whilst increasing range of motion. You also notice here that in the warm-up component and main session, some exercises contain blue writing, which notes that these were pain-provoking movements during testing. Therefore, a pain scale remaining under 4 out of 10 should be used as is shown by Smith et al. That pain may be permitted during exercise, provided it isn't too discomforting. Moreover, could actually suggest greater outcomes than pain-free exercise. And to the main session, we start off with cat-cows for trunk flexion and extension and scapular protraction, as shown by DeMay et al.'s study for improvements in scapular dyskinesia, or winging as we saw in Ken. And also bird dogs for abdominals, again an area of weakness, but looking to maintain a neutral spine throughout. It should be recognised that both of these exercises seek to address postural control issues, as shown by Mueller et al., suggesting that motor control training in the trunk can have a dose-response relationship for chronic lower back pain and disability. We've also got some isometric glute bridges with a hip tuck for his weak abdominals and glute maxes, but again, with a cueing of hip tuck to challenge motor control and stabilization also. A hip hinge for posterior chain weakness to mediate symptoms of chronic lower back pain, again, alongside all previous exercises. And we've done this as per research done by Tatar and et al., in which posterior chain strength can see large improvements in pain reduction, disability, and quality of life for chronic lower back pain patients. We've done a single arm row with a dumbbell as a combined exercise for anti-trunk lateral flexion and a row, which was an exercise suggested by Cools et al. For the treatment of scapular winging, irrespective of training history. A side-lying dumbbell external rotation from DeMay et al. Study for shoulder impingement symptoms that we've seen in Ken from both subjective and objective data, and finishing off the main session with a TheraBand shoulder flexion and abduction, both weak and painful areas, but more specifically is recognised by research to be effective movements in treating both shoulder impingement and supraspinatus tendinopathies. Now, all three of these exercises have been implemented for shoulder strength in areas that were deficits and have worked in guidance with early stage rehab for shoulder pathology in the articles spoken about. Seeing single plane movements to be the focus. And to finish off, we have a short cool down of low intensity walking broken up intermittently with static stretching that can assist with the areas of tightness Ken displays. This could include stretches such as a lunge, trunk extension, toe touch, and so on. Also, all training principles here in the table have been based off the studies talked about, have also considered Ken's lack of physical activity history, current pathologies, and are actually generally consistent with Australian physical activity guidelines. Okay, now we're going to take a quick look at the progression criteria, and this has been based off broadly some of the articles spoken about, and this is due to the fact that no guidelines have been published as of yet. First off, criteria that should be met for the intermediate stages for pain to be unnoticeable during daily life. 2 to 3 out of 10 pain and overhead movements and prolonged back bending. This allows us to see Ken with a full return to work, but possibly reducing working hours or for it to be broken up intermittently. Shoulder and hip range of motion symmetry within 10 to 15% and closer to norms, which is a common protocol for other musculoskeletal conditions at this stage of rehab. And finally, for all MMT to be 5 out of 5, here is the ability to withstand firm pressure by a practitioner can and should be achieved. For the final stage, criteria that should be met before beginning this is seeing pain-free movement in overhead and prolonged back bending that will allow full completion of leisure activities and work duties. Limb range of motion meeting norms, vast improvements in strength with asymmetry less than 10%, self-perceived confidence greater than 7 out of 10 in terms of Ken's personal belief on capabilities and his future outcomes. And finally, you certainly like to see Ken meeting the Australian Physical Activity Guidelines at this point. What I mean here is that Ken's weekly exercise plan should start to look more like general population as he shifts more towards a healthier life for the long term and with a less focus on rehabilitation.